All right. Well, welcome everyone. We are really excited about our programming today. Again, welcome to Connecting for Better Health. It's August. I can't believe how quickly the days are going. And as we're looking for the fall, hopefully we'll be seeing many of you in person with all the events that we're tracking. But let's go to our next slide, please, Olivia. Awesome. So we have a packed agenda for you today. Right at the top of the hour, we are welcoming Christine Mapile, who will give us some hot off the press insights into AB 1331, as well as other agenda items that she's tracking. And then we will move right into our advocacy work around AB 1331 and an update around where we are, the legislation that we're tracking. Then we also are going to be joined, we're so excited, by our partners at Partnership Health Plan as well as LA Care that are going to walk through how they are incentivizing health information exchange. This is really in line with our policy priority around funding and where and how we're kind of putting the pieces and parts together to be able to build capacity for data sharing in the state. And then we'll just wrap up with some announcements. And as always, if you have any announcements for us, please share them in the chat. And also, as we go through with our presentations today and our guests, please put your questions in the chat or raise your hand. We will try to get to you. If we can go to the next slide. So our coalition, we are all gathered around the shared vision of having really seamless information exchange, health information exchange, to be able to give our providers and our caregivers and ourselves and our families the information that we need to make great decisions. We also are coalescing around these pillars of policy priorities with our education around the data sharing agreement and the data exchange framework, funding that we'll be spotlighting today, where and how we can keep social services right at the front of the line and around the table as we are pulling together the pieces and parts around data exchange, and then also the work that we're doing to advance governance and accountability around the data exchange framework, which is a great introduction to AB 1331. So Christine, I think I see you on. Christine is a principal consultant for the California Assembly Committee on Health and has been really, I think, a chief architect of this work for AB 1331. So Christine, I want to hand it over to you.
Perfect. Hi, Timmy. Hi, everyone. Thanks for inviting me this morning. So I just wanted to give an update of AB 1331 by Dr. Wood. If you recall, AB 1331 was introduced last year, and it has many components. I think that, as Timmy had mentioned, it works upon or builds upon the TBL AB 133. One of the things that it does is it establishes a governance. So it establishes a board and its duties and responsibilities. It also establishes an enforcement mechanism, and then a component with respect to HIOs. The bill last year was made a 2-year bill in Senate Appropriations that allowed us time this year to work on this issue. I think last year, for whatever reason, the Senate wasn't ready for it to move. This year, I can say for certain that Dr. Wood intends to move it. So we are submitting amendments for consideration to Senate Appropriations. It still has all the components that is currently in the bill. So that includes governance, that includes enforcement, and it includes some component with respect to HIOs. Although I think it had more of a criteria in the bill right now. We're kind of dialing that back a little bit. So I can say that's one of the components that we're considering as amendments moving forward. Now, we have also heard from the administration that they also want to move AB 1331. I don't know exactly what that means in terms of whether or not they want to see governance, enforcement, and the HIO pieces. I um, I know that we've had numerous conversations with respect to enforcement, which really is, I'm going to highlight as a priority for Dr. Wood, because he really saw the enforcement piece as something, as a component that would make the framework successful. So at this point, I don't really know where they are going to land on the language. I just know that they really want to see something move at this point. We just don't know what that is. And as you know, the timing for these bills to move is really it's really limited at this point. Senate Appropriations has their suspense hearing next Thursday, and so amendments are due to them on Monday. After that, we probably have like a week for floor amendments, so it's going to move fairly quickly. But as always, we're hopeful, and of course, I'll keep you all apprised on what's going on with this bill. But I'm happy to answer any questions to me.
So Christine, I think the very top, I'm sure you saw our letter and
Hmm.
thank you to everybody who signed on to that letter. We also have been really focused on storytelling, but are
Hmm.
there um, other areas or ways, especially in this very condensed time frame, that you would suggest that we help to support getting it through?
I think the engagement that you all have done, with respect to Senate appropriations and on the Senate side, as I'd like to think that Dr. Wood has really been involved in this issue for a number of years now, and really it has just been Dr. Wood. And so anytime we hear from stakeholders, especially consumer groups like you all, I think that's important. Um, just to have our voices heard at this point, and to continue kind of lifting up this issue, because as Dr. Wood is this is his last year, but we're hoping we get something, and I think he's hopeful as well, since he's been doing this for a while. But yeah, I think the continued engagement with not only Senate Appropriation Committee members, but once we get off suspense, hopefully with the senators
Yeah,
as well for the
that's a good,
floor.
that's a good
Yeah,
point. And can you
yeah,
walk us through
yeah.
timing?
Yes,
And let's assume it gets through appropriations. What are next steps? That's many of the questions that are in
sure.
the. Yeah.
So suspense is going to be August 15th. And then the next week from the 19th through the 23rd, um, the 23rd is the last day to amend. So we will have to have drafts ready to go and submit to the Senate by that date. And as you know, it takes a while too, right? Because we have to have the draft. It has to go to legislative council, so that takes a while too. So we have to build in all of that. And I think the thing that is, well, for me, it's the timing, and it's waiting for the TA from the administration, because I
Mhm.
think really it's their engagement that is important. They say they want this bill, so they really need to help us first get it out of Senate approps, and then get it on the floor, and hopefully incorporate all the amendments that Dr. Wood agrees to into an RN, so we can get it into this bill. The thing about it is, we haven't received the technical assistance from the administration, but I'd also like to give an opportunity for Dr. Wood to review it. I mean, ultimately, it's Dr. Wood's bill, so.
Yeah. Um, so we went through, I was just writing down the dates. So August 15th and the 19th through the 23rd to amend. And
Mhm.
then if it gets passed,
With
then
amendments, then we
with
have
amendments,
we have until the 31st to pass the bill.
and then once it gets passed, it goes to the governor's desk to be
Mhm.
signed. And then I
Yes,
would think that that would be another opportunity for, well, I'm going to come back to that on this when we need to get it passed out of Senate. But once
yes,
it gets passed out of the Senate, then we can goes to the governor's desk. Then we have another opportunity for a letter writing to the governor to sign it.
yes, yes. That's right.
And he has until when to sign it? I
A
think it's
month after our session ends.
So one thing that we could do maybe as a coalition is to make available for everybody here who your senator is. So that when they are considering it, you can all reach out to your senator. Would that make sense to you, Christine?
Of course. And I can send you a list too with, the districts and yeah,
That would be great.
of course.
Other questions? Oh, I see. Yep. Thank you, Jonathan. Assuming that this bill goes through, when would it go into effect?
Right. January. Yep. Good question. January 2025.
Great.
Okay, so
And
let me, can I ask you just easier to speak
yeah,
on this
sure,
one?
of course, Jonathan.
Hi guys. So the reason I am asking these questions, not only because of my personal curiosity,
Sure.
but I have been advocating for this to the EMS and fire community
Yep.
for a while now, as some of you know. There are some folks in that community who I think incorrectly think this isn't going to go the distance. And the reason had to do something having to do with the appropriation, or if there's a cash requirement to it, and so on and so forth. Like I said, I think they're misreading it. But to the degree that we have been like things like the the clarifications in 1331, for example, the explicit mention of emergency medical services in line with Title 22 in California. Um, would those clarifications become binding in January, such that EMS and fire service? I mean, in other words, everything that's already in the bill 133, you
Mm-hmm.
guys now know you have to do,
Mm-hmm.
and if you haven't been watching it, tough for you. We've been trying to tell you you should watch it. Is that kind of where they're at?
I would say yes. So I'm
Okay.
looking at the bill right now, the clarification that emergency medical services,
Yeah.
yep, would have to apply with already existing requirements, for example, on health plans, general acute care hospitals, clinical laboratories. Yes, they would then have to comply with the clarification as of January 1.
So if at that, that's great. So it's not like there's, assuming this goes the distance, it gets signed off.
Yep.
It's basically, there's not really a lot of room that I could tell from reading the bill
Hmm.
for someone who runs an ambulance service in California to say, yeah, but that's not us. Like basically
That's
you
how I
missed a
read. Yep.
shot.
Hmm. Hmm. That's how
Okay.
I read the bill.
But then how long do they have to comply? Because obviously they're going to have steps that they need to go through where
Mhm.
everybody else has had a year
Yep.
to start getting cracking, right?
Yep.
These guys are going to have to start going through some steps. Does
Yep.
that impact them? And is there any sense of what happens if they don't
If they
participate?
don't. Yeah. So I think that I know from um the implementation of 133 that there are some entities that should have been complying that are not complying. And I think I will say that Dr. Wood was really concerned about that. And one of the things that he wanted to put in this particular bill, AB 1331, is the enforcement mechanisms. So I would say that once there's that clarification that EMS services have to comply just like everybody else, all those other healthcare entities that I mentioned, the my understanding is that they have to comply as of the date this bill becomes effective, which is 1/1/2025. Now, they should be following closely what's happening with legislation. And so just like any other entity that is impacted by a bill that becomes effective 1/1/2025, unless there's a delayed implementation, they will have to start complying with the law as of that date. That's just my understanding and how I kind of think about how laws are drafted and made and are implemented. So that's kind of what I would say. Now, does agency or the administration who implements and um, who currently has, authority over this law, do they have leeway? Probably, and they probably have a different perspective, but that's just kind of my simple high level read of how this would work.
And thank you. And you said the
Yeah.
enforcement mechanisms are delineated in the bill. I just
Yes,
don't remember seeing
there
those.
is there
What are
is
they?
some enforcement mechanism. I will say that the administration has some heartburn there. So I don't know exactly where we're going to land, but I know it was important. It is an important piece for Dr. Wood, and so we still have it there. There's two pieces. There's a piece about contracting. So if you participate in Medi-Cal, CalPERS, Covered California, then you have to sign and share information pursuant to this bill. And then there's also a piece that gives authority to the administration agency to come up with a framework, an enforcement framework.
All right. I mean, in our space, there tend to be basically three things. One is you can't sign contracts. So to
Yep,
your point, you're
yep,
barred basically. The second is fines, right?
yep,
Which again I think can be challenging, but they
yes,
exist. And the
yes,
third is delicensure.
yep,
And
yeah,
again, California, I think I can't really see them delicensing for
I
something like
know,
this.
I know.
Other states have.
Right, right.
But here we need all the ambulance services we got. So,
Yeah, I get it. I
yeah.
get it. I mean, it's tough because the its agency, or how they like to call the center, is the one that is overseeing the framework right now, even though each of the healthcare entities that are supposed to share information have, a different regulatory
Other
structure.
regulatory bodies.
And so the thing about it is, the agency is saying they're not established to do enforcement, to do penalties, to do corrective action. It's really those entities that have, for example, Department of Managed Healthcare over the health plans. So it's kind of tricky. So we've been trying to work that out, but I mean, that's what we have in the bill. It really is just having them establish something so that there's more teeth
Yeah.
to.
And
Yeah, from
accountability to each other.
yeah,
I'm
I mean,
gonna,
from my view,
Jonathan,
they'll self-regulate. So okay, I appreciate it. Thank you, guys.
Jonathan, I just want to be able to slip a couple more questions in,
Yep,
Felix.
sure.
Yes, thanks, Timmy, and thanks, Christine, so much for all of the persistence and hard work. It's been a journey, and I think we're all very much looking forward to a happy ending for those of us who support the bill. I wanted to actually bring up one thing that comes to mind when you talk about the administration, notwithstanding that they seem broadly supportive of the bill, which is great. It sounds like they're telling you that they have reservations about some of the enforcement deadlines in the bill. I believe the current version says that contracting, that signing the DSA is going to be a requirement for contracting with Covered California and DHCS, et cetera, by 2026. And that seems, in their view, to be a bit too soon, I guess, or not as far out as they would like it to be. I just wanted to point out as a counterpoint that Covered California is not even actually waiting for this bill to become law. I have it on pretty good record that last week they had a public meeting with their contracting team and all of the qualified health plans, and they previewed upcoming contract changes for the 25-26 cycle. And one of the amendments that they're proposing to the contract with the QHPs is to actually require DSA and DXF compliance from the plans, and also for the plans to monitor the compliance of their networks, hospitals and providers, to make sure that they are following through with their DXF obligations. And that's all happening again as early as 2025. So if and when you hear back from the administration that 2026 is a bridge too far when it comes to enforcing the DSA, I would really point them towards their own agency, Covered California, as being an example that this can and should be done as soon as possible.
And thank you, Felix, for bringing that up, because as we have our health plans on today, the ask is out to Cover California too. So hopefully they'll be able to preview that once it's made public. We're really eager to see it. But Christine, I think the point is well taken that there are already steps out there. And also with DHCS too, we can point to other contractual requirements that are in multiple different contracts and grant programs, etc., that we are tracking. Any other questions for Christine? Well, thank you, Christine. The floor is yours. Do you have any other high priority areas that you would like to relay to this group?
I think You know, really, I think I'm hoping that this crosses the finish line for Dr. Wood. As I mentioned at the top, he's been working on this issue for such a long time now, and it's an important issue for him, with respect to the sharing of information and all, you know, really with the penalties, the enforcement, some sort of framework. It's important to him because he just wants a level playing field. And he just wants to ensure that people are sharing the information so that the public has it. And so again, it's just, you know, it's just, I just really wanted to highlight that he's been working on this for such a long time. And so for him to get this before he leaves, I mean, would be great. And I think it would be great for the framework. So.
We agree. And thank you for your leadership as well. We really appreciate your partnership. And we are here. So if at any point you think that we would be helpful, please don't hesitate to call on us, and we'll follow up with you with the, you know, the ask to senators, and then also for the governor. And thank you. And, you know, and we also appreciate Dr. Wood's leadership as well. We wouldn't be here without him. And you. So thank you. Okay, well, let's move on to our additional work on AB 1331. I'm going to hand it off to Stephanie, who's been working so hard on this for everybody here.
Thanks, Timmy, and thanks so much, Christine. Really quickly, just in the interest of time, but just wanted to make sure folks saw the Connecting for Better Health letter that was submitted to Senate Appropriations earlier this week. So fantastic to see all of you here today and all these logos on here together. Really, really just so much thank you. So much gratitude from the Connecting for Better Health team for those of you who joined us. As Timmy mentioned, there will be more opportunities. We heard from a couple folks this week already who weren't able to sign on this week, but want to support down the line. Fingers crossed for next week's hearing, and you'll definitely be hearing more from us related to future opportunities. And I'll also just share, we'll pop in the chat the link to an op-ed by Timmy that many of you likely saw at the end of last week in Capitol Weekly around AB 1331. I think in the interest of getting to our health plan presentations, we can move on pretty quickly here. Just wanted to once again uplift these amazing stories that many of you have contributed around the impact of data exchange. These are all up on our social media and website, and we'll continue to push these out and use these particularly when we have conversations with our senators on the impact of data exchange. Next slide.
Stephanie, I think we also, our ask is that everybody should be following it. They're up on our socials. Please repost them, reuse them. You know, we keep hearing storytelling is so important. So even when you're thinking about reaching out to your senator, you could use these stories or come up with the stories that are in your own district. But it's important for us to get these out.
Absolutely. Yes. Christine gave us a good overview of the schedule, but just a quick reminder on key dates here. And I think that I can pass it over to the next slide here. Maya, do you want to do a quick overview of our ledge tracking before we jump into our presentations?
Yes, this is a lot of reiteration of what Christine was saying, but appropriation hearings are in full swing right now. Most of the bills that we are tracking have been referred to suspense file, and the suspense hearings for both appropriation meetings are next Thursday, the 15th, so we'll have a lot more updates then.
Timmy, we could probably send out a special ledge email or something like that at the end of next week, just given how much is likely to happen next week.
I think that's a great idea. So everyone if you have any that you in particular want us to watch for you, we're happy to do that. And then we can also make sure that we give an overall update. I love that idea. Okay, well, thank you. And I am hoping that our health plan representatives are on. Dr. Rabordi, are you on? Yes, I see you, Jeff.
Yeah, I'm here.
Okay, fantastic. I am just so pleased to be able to introduce our health plan participants today. Partnership gave a preview of this presentation earlier this year at the California Association of Health Plans. And we really want to start bundling and tracking these incentives, and imagine, if you will, an inventory that's available up on our website so that we can start coalescing these and hopefully start some momentum. So thank you for your leadership at Partnership. You've been doing this a very long time. We welcome for you to walk through these incentives that you have in place, and hopefully it sparks some ideas for other plans and other organizations, frankly, to be able to follow in your path. So please take it away.
Great. Do you want me to share the presentation, or do you guys have it?
We have it, so we'll just,
Okay.
if you just let us know.
Okay. Yeah, let's go ahead and start the first slide. So my name is Jeff Robordi, as you mentioned. I am the Northwest Region Medical Director for Partnership. I live and work in Humboldt County. I was a primary care pediatrician full-time prior to working at Partnership full-time, and I still continue to live in Humboldt County. So let's go ahead and go to the next slide. And I just wanted to, just for those that don't know us, just a little introduction about Partnership. We're a safety net public health plan. At the present, we're Medi-Cal only, but as you know, all plans will be required to have a D-SNP Medicare product by 2026. So we are working on that. We are a nonprofit. We have a low administrative rate, about 5 to 6%, that allows us to invest more into our provider networks and communities. We are governed by the counties that we are in, and as you can see, we are now in 24 counties in California. We will eventually take over the state once we build up our armies. But we have 6 regional offices presently. The little dots show you where they're at. Like I said, I'm in the Eureka one. Basically just a lot of community involvement. Our employees work in the communities, or live in the communities that we represent. So just a little quick introduction there. Go ahead and go to the next slide. And I think this is just more about us, our mission or vision. Right now we have just under 900,000 members as of July of 2024. And all the population in our region, about a third, are Partnership members. So we do represent a good chunk of the population. All right, go ahead. And this is just a timeline of Partnership's history. We just celebrated our 30th anniversary. I haven't been here that long, but I've been here for 11 years. So go ahead and go to the next. So at Partnership, we have a lot of quality improvement programs, otherwise known as pay for performance. We rely on obviously a lot of data to try and meet these measures, and to have our provider network meet these measures. We're pretty much data nerds here, so any and all data we want. Sometimes we get so much data we don't even know what to do with it. So, but we've really made a lot of inroads with a lot of organizations to try and get this data. So I'm going to talk mostly about our hospital quality improvement program, because they currently have the most incentives for data exchange in them. So this QIPs, we call them, been around since 2012, and this is a way to give financial incentives to hospitals that meet performance targets for quality and efficiency. And then I'll show you some of our other QIP programs. These are the measurements that are in these 6 areas. I didn't put the whole measurement set on here. It gets kind of complicated because we split it between large and small hospitals. We have about 50 hospitals across our counties. And I put a link in, though, if you really want to nerd out and see our entire framework for the hospital QIP, it's pretty detailed. So go ahead and go to the next slide. So our main focus so far has been on okay, so let me start over. So we used to make, we had a very, before all this kind of came out, we had a very rudimentary kind of gateway measure for members or for hospitals to use data exchange to actually even participate. And we still kind of have that. And we are requiring that being or using ED and other HIEs is really a prerequisite to participating in the hospital QIP. So if you have no connections and are not working on getting those connections, you basically can't earn any money in the hospital QIP. So it still is somewhat of a gateway measure, but there's more gates to go through now. So and the reason we do that is, like I said, we need the data, and higher quality scores are obviously shown to be better quality usually, and actually savings hospital saving money for the hospital as well. So we have three different classes of HIE that we require. We require them to be connected to a community HIE, which in our network there's really only two. And then we also require them to use ED, which is now part of point-click care. This is used a lot for visits to emergency rooms and to track people in actually, especially in our ECM and in the social services. And then we also would like them, well, require them to be part of some national HIE networks network. And we have a list of those later on. So let's go ahead and go to the next slide. And then this is the more detailed information. So we want the hospitals to maintain a HIE interface to include ADT, and then HL7, or all these other technical terms, some kind of radiology interface, any of these things. So our two community HIEs are Sac Valley MedShare, which covers the larger portion of our network, especially in the eastern counties. In more of our southern region. And then we have the North Coast Health Information and Improvement Network, which covers Humboldt and Del Norte counties. I don't know if I have to disclose this, but I'm on the board for NCHIN, so but I'm not getting paid by anybody. So and but those are the two that we use. They're both really well, like I should say, I'm on Sac Valley MedShare board too. These are great organizations. They've done a lot of work in this area, and we get a lot of data from them, and we have a long-standing relationship, especially with NCHIN. And then we're requiring the level 1 data elements at this point, but we recommend, if you can, to start working or get to level 2, because that is going to be a perfect standard. And then there's a link to that, to talking about the differences between level 1 and level 2. Next slide. And then for the ED requirement, we want them to do ADT using point-click care's ED. Well, it's now they're a part of their bigger software. This can be done either directly with them or through another HIE. And then here's some of the national networks that we would recommend. And then if they have another one that it's not on our list, but it meets requirements, we're always willing to look at those and make sure that they meet our needs. So next slide. So this is how we kind of incentivize it. Basically, depending on what stage they are and in their implementation, you can earn, as I said, if they're not doing any work with any of the interfaces, 0% up to 100%. So if they have the ADT plus HL7, blah, 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 stage 1, like I said, we're not requiring stage 2 at this point, link to national network and integration with ED, then you earn 100% of the potential dollars based on their score. So their scoring is one thing with all the different clinical measures, and then this is kind of layered on top of what they get. So if they're a little behind, their payout's going to be a little bit less. So the amount of payout is going to be different for each hospital, like I said, depending on their scores, depending on their size, all these things. So this is what we're doing in our current year. Yeah, so it's pretty straightforward.
Jeff, we may
And-
be good for this, but what is
Yeah.
your compliance level?
Well, this is new, so I don't know yet. We don't know yet.
Okay, this is
Yeah.
rolling out, right?
Rolling
Okay.
in, yeah, rolling
Got it,
out,
got it.
exactly. Yeah. Before, I mean, I think just about every hospital in our network has participated. I think there's a couple of that either have chosen not to participate or haven't met the measures, but for the most part, most of them are. So, and we try to give them assistance as much as we can, other than sending like, you know, an IT person to their hospital. So.
Great.
So the other HAE requirements is that they need to use the hospital quality improvement platform. For new members, they need to have some, you know, proof of enrollment, at least one submission of data, just so we know that they're using it and that it works. And then the last part is to continue submitting monthly discharge data. And then for ones that are already signed up with HQI, just showing that they're using it by timely and, you know, monthly submissions that we monitor. So not a terrible ask there. And then also as part of our obstetric measures, they need to submit data to the California Maternal Quality Care Collaborative, and then we pull the data down from there. Of course, they must authorize to be able to look at that data. So that's how we get a lot of our hospital obstetrics perinatal data. So go ahead and go to the next slide. And then some of the other QIPs that we have, our largest is obviously the PCP, the primary care provider QIP. We've had a number of initiatives over the years to get people to use HIE and other data elements. This is our largest QIP. Every year we pay out usually between $20 and $30 million to PCP providers across our network. So we have our regular clinical measures, like with the hospital ones, and then we have something called unit of service measures. We kind of call these bonus measures. They're not required to do these, but if you do, then there's extra money involved. So if a PCP and we do it at the parent level, not necessarily the site. So if they are signed up with an HIE, which most of them are, the first year they get a $3,000 incentive for signing up. And then annually, as long as they show continued participation, they get $1,500. Not a huge incentive, but you know, every little bit helps. And then if they're using ECDS, you get $5,000 per parent organization if the vendor is helping them with the interface and generating the reports, or $10,000 if they're a smaller clinic, smaller site, which some of our clinics are pretty small and don't have a lot of IT support or vendor support, then we will give them $10,000 to kind of help with that. And then what we use ECDS for is these measures, and we'll probably be using it for more measures in the future. So this is a starting point. So. And I think we have a couple other ones. We have an ECM QIP. It's a pretty small QIP. That's the Enhanced Care Management through CalAIM. And we want them also, point click care. You think that would be easy to say. And they're supposed to update their care plans, ROI forms, things like that. And that's just part of what they need to do to get the incentive. It's just we basically pay them a little bit higher capitation rate for that. And then we actually have a palliative care QIP as well. And we want them to use the Palliative Care Quality Collaborative, and then we give them up to $120 per member enrolled of their members enrolled in the program, as long as they're using the PCQC, which I believe all of them are at this point. So, and go ahead and go to the next slide. Oh, and then our perinatal QIP. We have a couple other QIPs too, but these are the ones that kind of fit the bill for this. So same thing, using ECDS in perinatal measures. The one so far is depression screening, and then kind of the same criteria as before, 5,000 or 10,000, depending if they have vendor support. And then HEDIS roadmap, same thing, 10,000, 5,000. This is really important because we have our QIP scores and we have our HEDIS scores, which is what the state looks at. However, for HEDIS measures, we cannot use hybrid data. We can only use claims data. So it's really important to get that claims data for QIP, because our QIP scores do tend to be, for some of them, 10 to 20 points higher, because providers are allowed to upload hybrid data, at the end of the year and stuff. So HEDIS is really important to try and get, like I said, every bit of data that we can. So, and then go ahead and go to the next one. I think that's, yeah. So these are references if you want. There's a link to all of our quality and performance QIPs, basically. Specific link to the hospital QIP. You can see all the specifications on that. It's like 30, 40 pages long. It's pretty detailed. And then our PCP QIP, which is our largest QIP. And I think that's it. I went through that pretty fast.
I'm going to, this is fabulous. And I think there's just, as I'm thinking about us inventorying these different incentives across plans, it's not just that what you started, it's also in all of those other additional quality-based programs, there's a data component to it.
Oh yeah,
And
absolutely.
thinking through how to build that capacity for that better data exchange, which is fantastic.
Yeah.
So I'm going to have Sai come on, and I would love for folks to have questions, and maybe once, Sai, if you can walk through yours, then we can have Jeff, if you could come back, then we can both, you can both address questions. Does that sound good? Great. Sai, are you here?
I'm here, Timmy. Good morning, everyone. Sai Wadela, Elecare Health Plan, Advisor Health Information Technology. My team is responsible for everything and anything HIEs at Elecare, and we work closely with our providers as well as our internal stakeholders to move the quality of care forward. Next slide, please. Just a brief on, at Elecare, we have a robust health information ecosystem. We call it ecosystem because, we have multiple health information exchanges and other interoperability systems. It all come together cohesively with extensive market penetration. When we look at HIEs, we don't look at one single HIE. We look at ecosystem as a whole and look at market penetration and see how well we can tap into the real-time member information and use that information to better improve care for members. And our goal is, as a health plan, our goal is to maximize quality of care and also maximize the amount of data that we can access from our network to achieve the quadruple aim. From a health information ecosystem perspective, our goal is to get at least 90% of the market penetration across different facilities that we have, that we're contracted with, including hospitals, clinics, SNFs, and IPAs. Our ecosystem has 3 different HIEs. The regional ones, Lanes, Lanes is our strategic partner. We are contracted with Lanes. eConnect is our homegrown solution. Actually, it's not available to anybody else. Basically, we use this solution to connect to, it's been live from almost 10 years. We use that solution to connect to all of our contracted hospitals. And we have a good chunk of hospitals, that are connected to eConnect. And again, like I mentioned, it's not available for others. We also use Pointly Care. We consider it as a national network as they operate across the country. And across 3 networks, the current market penetration that we have is we are pretty much connected to 74% of our contracted hospitals, at least 75% of our FQHCs and 70% of the skilled nursing facilities. All these at least our facilities are connected to at least one of these networks. So again, like I mentioned, we look at as an ecosystem cohesively, not individually. And through the ecosystem, we have an ability to achieve greater market penetration than looking at a single silos. Next slide, please. And briefly jumping into different financial incentives that we have available, we have invested pretty heavily in our health information ecosystem infrastructure. And our objective behind the financial incentive is to provide a sustainable way to incentivize and support our providers to make sure they're not only adopting HIEs, but also meaningfully exchanging the data. The goal is to not only for the benefit of the plan, but for the benefit of the network as well. So we want providers to exchange data between each other so that they are aware when the members move from one facility to another facility and build a network. And basically, these initiatives are targeting major touch points across different provider categories. We have initiatives for the hospitals, we have initiatives for the SNFs, we have for PCPs, and we have for IPAs. So we wanted to make sure that we have some way of incentivizing each and every provider type that we are working with. And we have structured it two ways. One is the one-time HIE adoption incentive. These are one-time seed grants that we provide to our hospitals. Basically, this covers the first year of subscription fee as well as any implementation costs that they incur. And total, we have around $5 million available for those one-time incentives. Right now, we have it available for the hospitals, SNFs, and FQSCs and small and solo providers. We don't have one-time implementation for the IPAs, but for the majority of the providers, we have available, and it's currently live. And for the next 3 years, they have dollars available that they can tap into and apply for. Additionally, we also have incentives through our Pay for Performance program. So what we have done is we have added a HIE participation measure in all of our Pay for Performance programs, including our hospital P4P, SNF P4P. We have a physician P4P, and we also have a VIP, which is for the IPAs. So through this avenue and vehicle, we have approximately $9 million per year allocated for just HIE participation alone. So all these providers could earn almost $9 million if they meet the HIE participation milestones. So this way, this allows us to provide some sort of sustainable funding on an ongoing basis rather than giving one-off grants. The one-time, again, like I mentioned, the one-time, we do have one-time funding available. That's just to get them going and get them connected. And provides them with some sort of seed funding, where for P4Ps, provides them with ongoing incentives so that they can meet the milestones and get paid, and in turn use that money to offset some of the costs that they incur for participating in HIEs, because there's a cost involved as well. Next slide, please. And just these are some of the milestones that we use. I just shared some of the common milestones. Again, these milestones are structured differently for different programs. For hospital P4P, these milestones are structured differently, whereas the physician P4P, they are structured differently. But these are just the common milestones across the board. So one of the first milestones is basically they have to sign a DSA with CalHHS. Since it also ties to the compliance, we wanted to make sure that as a plan, we are ultimately will be obligated to make sure that our network is participating in DXF, and we used our P4P and HIE participation measure as one way to get them into compliance and also incentivize them for doing so. So they have to sign a DSA with CalHHS, and the second milestone is basically they have to sign a participation agreement with either Lanes or Point-Click-Care, or they also go by Collective Medical Technology. Again, eConnect is not available, but at least they have to sign up with either Lanes or CMT. The third milestone is they have to send the ADTs and CCDs to Lanes and Lanes or PCC, not just ADTs, but we also want them to send the CCDs as well. And the last milestone is they have to also receive, because the intent is for them not just to send it, but also in turn receive it and use it to coordinate care for members. So that we can move the needle on different measures that requires follow-up. For example, follow-up after hospitalization for mental illness, which requires the providers to follow up within 7 days after hospitalization with a mental health condition. So we wanted to make sure that we move the needle on those HEDIS measures so that the data is actually meaningful and useful to coordinate care, rather than just sending us the data, which is great. We can use that, but we also want to make sure that the provider also receive it and use it in a meaningful way. I believe this is my last slide. Timmy, back to you.
Yes, I just wanted to ask a question on this. So this is an example of the milestones that you use in your Pay for Performance program. Is that correct?
That's correct. And we use the same milestones for our one-time incentive as well. It's a performance-based incentive where they have to meet to get the money, but these are just the standard milestones that we use across the board.
And we have a question around, I think for both of you, and Dr. Bodhi, if you could come back on too. But Jonathan asks whether or not you've included any of the medical transportation providers or EMS in any of your incentives, if you know that.
We haven't at this point. We've taken our transportation benefit in-house, and we've been dealing with all the fallout from that over the last year. I don't know if we're planning on doing that. I haven't heard anything, and same thing with EMS. I know EMS rates are pretty poor, and probably something that we'll be working on in the next couple of years.
Something to think about. Sai, do you know if you have?
No, currently our incentives are mainly available for hospital SNFs and our PCPs. I think that's a gap. We are aware of that. We don't have an incentive or method to incentivize our specialists.
I was just going to ask for the specialists, and that was another question too. And it looks like partnership is looking at that in the future.
We had a specialist QIP, but it wasn't like a quality improvement program, because obviously, such varied specialists, you can't have quality measures for them. It was basically based on number of visits, basically how many of our members they were seeing, and then a bonus, payment based on that. But we don't have one currently. I'm not sure why we stopped that, but yeah, so it's hard to do, like I said, quality measures for specialists, but we try and pay them enhanced rates and good contract terms.
Well, and I love the line of questioning here, and I see Wilma, you are asking about, are there any incentives for your community or public health departments or other county-based groups? And that's where we are, especially with CalAIM being rolled out. There's just more providers with the capital P and a lowercase p.
Well, it's funny. My regional director and we just had a meeting with Lake County Public Health Department last week, and that was an ask of hers. And we're like, we've never done that before, and I don't even know what the regulations are around that. Are we allowed to pay, public health directly? So it brings up a whole nother issue that I have no knowledge or experience in. But yeah, I mean, their funding from the state is also pretty poor. So.
Right. Sai, do you have any thoughts there?
Not I can think of right now.
Okay. And Doug, you have your hand raised.
Hi, everyone. Sorry, I've been absent. I've been busy over with my new role.
We've missed you.
Thank you, Timmy. I miss you guys too. I really hope we can get this connection with specialties, because that's where I'm getting the most traction with doctors that want to get involved with ECM and with this whole person care we're trying to do here in California, because they land in our specialist office with those higher needs. PCPs just do not take care of people with chronic conditions anymore. They just don't have the bandwidth, and they're dealing with HEDIS and all these other preventive screening, which is where I want them to be. I mean, we want to transition to healthcare instead of sick care, and we need to do that through PCPs. But what I was hoping that they would do something along with, your care coordination agencies that we're building for our ECM programs, if we can figure a way to weave this in with some incentives for them too, because that's where I'll have our nurse practitioners and case managers that are really connecting all the dots for these patients with their higher needs.
Thank you for bringing that up, and it's definitely in our line of sight for Connecting for Better Health too, of every single one of these of CalAIM and how it's being rolled out in all of our work across different counties. We hear this need for being able to educate and bring in the data exchange framework into the data sharing agreement into the conversation, and that aligns as well as making sure that social services is really kept and has a seat at the table. So thank you, Doug. And
I was happy to see point click care referenced here, but I don't know where they are on the data exchange framework roadmap. I don't think they're actually sharing their data yet. I don't know. I don't see it here because I have Care Everywhere is what I use to tap into Lanes and the other HIEs, but I don't see my data for my patients in the SNFs, that will be gathered through Point Click Care. So are they sharing their SNF information, or what are they doing with that?
Great point, and also another segue into our sandbox, because they are involved in our sandbox. And I think that is exactly what we're trying to tackle, is how does this information come together as it goes through so many different hops? Are organizations able to get what they need in order to make good decisions? So really good point, Doug.
You know me, Timmy. I'm always coming up with this
Yeah,
stuff.
and we'll follow up with
Sorry.
our design work.
But yeah, I miss being in the mix here. So I'm happy to be back.
Super. Well, I'm looking at the time. I want to keep us moving. Thank you both, Partnership and LA Care, for the presentations today. We're eager and hungry for this work. Keep it going. And we will catalog this. And, I'd love to be able to have a place for us to compare incentives across organizations, and especially to be provider centric. And we all know that when providers are incentivized to do different things in different ways, we're not really able to kind of, get to the finish line. So if we can get some consolidation and, more momentum in going in the same direction, I think would be really helpful. So we'll do that. If any of you are aware of other plans, we know IHP presented, we'll follow up with them. Covered California was also mentioned at the start of the call. We're following up with them. But if you have other plans that you would like for us to highlight, HealthNet has theirs too, and we'll put this all in a place, and then we'll keep adding to it and make it iterative. Yes, thank you both. Okay, I think we can wrap here. Quick news and announcements. I will just make the quick announcement for the sandbox. We mentioned this on our last call. For those of you who would like to log in, and it is now live, you can do all the reporting of the participant directory is available here. Our visualizations are incredible. As you sit down and start thinking about who signed the data sharing agreement, who has signed a participant directory, and how are we going to really do meaningful data exchange in a region, this is a great place to start. And then also to access all of our use cases, our test data, and we'll be continuing to add on to it here. So please go in and poke around and let us know how you think it could be useful to you. And then Stephanie, I'm going to hand it off to you for the quick announcements.
Sure. Olivia, you want to hop in with anything from newsletter?
Just to check it out and subscribe, I'll add our link in the chat, but we've been tracking the latest both in California and nationwide. So to stay up to date, would recommend subscribing.
And also in that newsletter is always our list of upcoming events. Just once again, Timmy mentioned this at the beginning. For those of you who are hosting events or in speaking places related to data exchange, please send them our way. We'd love to include your events here and in our materials. And I think that's it. It's right about 12 o'clock. Thanks, everyone.
Yeah, thank you, everyone. Call to action, get up on socials, repost, get the word out for AB 1331. Reach out to us. Let us know what you need. We'll talk.
Thanks, everyone.
Thank you. Thank you, everybody.
Thank you.